Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gollin.
Welcome to the Gastro Girl podcast and the final episode of our special 4-part series on GERD and Barrett's esophagus, sponsored by Castle Biosciences and brought to you in collaboration with expert clinicians and researchers dedicated to improving patient outcomes. I'm your host, Jacqueline Gollin, and if you've been with us throughout this series, you've learned that chronic acid reflux isn't something to ignore. In episode 1, we discussed how GERD can lead to Barrett's esophagus and why that matters. In episode 2, we learned how Barrett's is diagnosed and how tools like TissueCypher can help personalize risk. And in our most recent episode, we heard about how patients at high risk can be treated with endoscopic therapies and how important it is for all patients to manage their reflux through lifestyle, medication, or surgery. This episode is all about what happens next, whether you've just been diagnosed, completed treatment, or are navigating life with chronic reflux. I'm joined by Tedra Gray, a seasoned advanced practice provider who works closely with patients navigating GERD, Barrett's esophagus, and everything in between. She's here to help us understand what it means to be an active participant in your care and how to turn awareness into real empowered action. Thank you, Tedra, for joining us on this episode today. So nice to see you.
It's great to be here. Thank you so much for having me.
Oh, you're so welcome. So, as you know, we've covered a lot in the last 3 episodes of this series, and we're looking to you to help us today to kind of connect the dots as we talk about what patients should do next. So let's take it from a couple of patient scenarios. Maybe there's the patient that has GERD and heard our podcast about Barrett's esophagus, and now they're wondering what they should do next. What do you suggest, or how would you guide them?
I would guide them first by really kind of taking a journal of their symptoms, thinking about when did they first begin, how often are they experiencing them, and are there any necessary food triggers or not food triggers, and then really catalog that information and bring it to their primary care physician to have an in-depth discussion, really trying to identify risk stratification and then pursuing or directing the patient on to the next step to see the gastroenterologist. GERD is a symptom that most patients experience, or heartburn symptoms are most symptoms that patients experience. However, really understanding when they become concerning is appropriate to discuss with their primary care physician.
Thank you. So we've heard that early detection is so key, and Barrett's esophagus is highly treatable if caught early. So how is this? Can you recap how it's diagnosed, or you said risk stratified, so patients understand their next step?
Sure, certainly. Barrett's esophagus is diagnosed by doing an endoscopy or a procedure, same-day procedure by a gastroenterologist. It's something that is a very quick test, very simple, not a lot of preparation prior to. However, it's really identified or specified for that patient who has, like I said, persistent GERD more than 3 times a week for greater than a couple of years. And then it's really concerning for that patient who has tried over-the-counter medications, tried prescriptive medications, and they're not getting relief of symptoms, or symptoms recur. So doing that endoscopy is how you can do early detection of Barrett's esophagus and identify a treatment pathway that is consistent with the patient's needs and desires. We know that Barrett's esophagus is a precursor to esophageal cancer and that it can be life-threatening. And however, if it's caught early, it's highly treatable.
Thank you. Now, Tedra, you've worked with all kinds of patients, and we all don't respond to the news of being diagnosed with the condition the same way. So can you walk us through different personality types and how they may approach a diagnosis like Barrett's esophagus? And I think this is important because when patients listen in, or individuals, it's really helpful, as you know, that they identify with what they're hearing. So I think this is a really important question.
It definitely is. I mean, I think how patients respond depends upon their age, it depends upon their socioeconomic status, and it depends upon just their overall demeanor. So you have that calm patient, that methodical thinker who functions on facts and is proactive with pharmacological responsibilities. And then you have those others who are anxious, who are overwhelmed by conceptualizing the impact and long-term medical implications. Some are skeptical. They don't necessarily feel pain. But they believe that reflux has not been that bad or has caused that much damage. You have some patients who are just overwhelmed by, like I said, those socioeconomic situations where they have days off from work for procedures or cost of long-term medications. So really kind of framing what type of patient you're dealing with is essential in creating that care plan.
So how do you meet them where they are, like, emotionally, and give them the tools to make informed choices? Like, what are some of the tips and suggestions that you have for approaching those types of situations?
Well, typically as a clinician, I set aside literally the medical aspect of the conversation and just kind of ask them to tell me what is their life like. Give me an example of who lives in the home with them, what types of family activities do they enjoy sharing in, what type of job do they have? Do they have children? What are their work schedules? Really trying to paint a picture of what their life is like outside the office. So then we can craft and create a treatment plan that aids in creating that life integration that's so essential when it comes to medical care.
Well, I love that you've touching on shared decision making. That's just such a I love that terminology, and it's really empowered the patients to be an active participant in decision making with their provider, like yourself. Um, how does that? Can you explain a little more about the role of shared decision making and how that helps you build a care plan that the patient feels comfortable with and that can actually implement in their daily life?
Absolutely. Shared decision making is it's a collaboration. It's a practice between the provider who brings one aspect to the conversations, which is the medical knowledge, and then it brings the other aspect of the conversation, the patient, and their preferences, their values, their morals to the conversation as well. I mean, patients who understand the risks that they are going to meet with this disease, they're more likely to be compliant with medications, to come to follow-ups, to send portal chat messages when things are not working out as such. And they're more apt to incorporate lifestyle changes, whether it be exercise or dietary changes. They're more apt to incorporate those into their lifestyle and then also bring their families along in conversations that they might change the whole trajectory of their family dynamics with being proactive and having a voice to this disease. It's not a one size fits all conversation, and it's definitely not a directive. The anticipated outcome is really kind of create a balanced prescriptive partnership of patient empowerment and incorporating provider expertise.
Tedra, that's such an important point because we see this all the time. Patients see a video or a podcast, or they're reading something about a patient who did X, Y, and Z. And they're like, oh, I want to know exactly what that patient did. I want to do that. Let's highlight a little more why it's not a one size fits all, because so many of us think that, oh my God, this worked for them, it's going to work for me.
100%. I think a lot of factors go into reflux symptoms and why one may be predisposed versus the other, as well as like just anatomical situations that might occur within the GI tract, dietary exposure. Certain demographics have different dietary uh, considerations, so that might predispose to more of a reflux type of pattern. You have things that we can't modify, like gender or race, that could predispose you to developing reflux and then subsequently going on to Barrett's. So it's a lot of concepts that we need to explain that um, impact this disease. So it's not a one size fits all.
No, thank you again for highlighting that. Now, this is the fun part. I love this part when we share examples of patients with different risk levels and how their camp care, excuse me, and how their care plans may have been tailored to them. So, can you highlight maybe one or two cases to give us an example of that?
Certainly, certainly. What comes top of mind in regards to a low risk patient, and that's a patient who just had some casual reflux disease, had been suffering for years, kind of doing some over the counter medication treatments options, and then finally decided to bring it to her primary care physician. She was subsequently ushered on to our gastroenterology clinic, and when further discussion, she had really marched herself through the precursors of all that she could do, but really kind of explaining the context of when too long and too much reflux will become an issue. So she subsequently had an endoscopy. And in addition to the normal treatment that goes into doing a procedure, biopsies were taken. And then once I saw the pathology of the biopsies, I was able to do an additional test to help mitigate and direct my further care is really trying to identify if she's a low risk patient by doing an additional test called TissueCypher. And for her, she fell into the low risk category. So having that conversation with her, really painting the picture of not only the visual inspection, the histological response, as well as the anticipation of what would happen in the future, allowed us to come with a shared decision-making plan of surveillance. It increased her understanding of really how important lifestyle modifications were. And she ultimately did well. She ultimately has really made an impact not only in her life, but in the life of her family.
No, thank you. Before you get into the high risk patient, I want to clarify when we talk about low risk and high risk, we're talking about the risk that a patient has for that Barrett's esophagus to turn into cancer, correct?
Yes,
Okay.
yes.
Thank you. Okay, now let's talk about case number 2.
Oh, this is a joy. So this high risk patient really was a patient that actually came into the hospital for a completely different issue and ultimately still needed an endoscopy, but for a different reason. And the Barrett's was incident, I should say the reflux and the esophagitis was incidentally found. And so in that case, there wasn't that precursor conversation. There wasn't that, oh, I've been struggling with reflux. It's not helping. This patient wasn't really attached to a primary care physician. So didn't really have good healthcare guardrails, if you will. So having received that biopsy result and looking at that interpretation and then sending it on to TissueCypher to really kind of frame what and project what will happen next, he came back as high risk. So it was really a challenge because of some of his other socioeconomic issues to capture him, number one, and then try to really explain not only what was causing his initial pathology that caused the endoscopy, but you also have this other undercurrent that really didn't exhibit to you in your daily life an issue. However, it is something that's on the horizon. And so he had a high risk. And so his follow-up changed and more intensive lifestyle support was implemented.
That's very interesting. Now, was he having a lot of symptoms of anything to bring him to be able to get that that endoscopy? Because that was key.
He's having symptoms, but his symptoms were masked by some substance abuse. So it wasn't top of mind.
Okay.
However, once he was able to control the substance abuse, he was able to then really kind of, it was highlighted even more, the expression of the heartburn that he was experiencing.
Oh, thank you for that insight. It's so important. Now, I'm sure you deal with this so much is, patients who struggle with medication compliance, especially with PPIs. What would you say to them? What do you say to your patients who are struggling with keeping up with taking their treatment plan meds?
And that's a conversation that we often have. Compliance isn't just about creating a habit. It's about understanding why you're doing what you're doing. It's about understanding on a conceptual level for the patients what exactly is happening by me taking this one pill a day. So that first prescriptive, whether it be that first prescriptive daily medication that patient is ever taking in life, like how do I incorporate that into my lifestyle? Do they have a non-traditional meal time? Maybe they work overnight, a night shift. So just discover the habits that will aid in successfully taking the medication is a key to compliance for me. So I really have that discussion of painting the picture for me as a clinician. What does your day look like? When do you see yourself really being able to consistently hit the mark and take this medication?
Yeah, and one of the things where we've seen some really eye-opening questions is the mechanism of action and how that helps patients understand why that medication was prescribed to them and the importance of taking that, as you say, understanding and how it fits in their lifestyle. But why? And, how do you address that with your patients? Like, I think this is a great point to make for those listening out there.
Oh, yeah, I'm a visual learner, so I kind of try to paint the picture of a visual experience for the patients when I'm trying to explain. So I often use the description of sprinklers that are in the ground in your lawn. And so what you're trying to achieve by taking the acid medication is covering the sprinklers before they pop up. And so you can decrease the acid exposure. So if the sprinklers have already come up and they're already turned on and you're trying to run through the lawn and cover them, you're getting wet. Acid is everywhere, and you're not really able to control or achieve the mitigation of acid suppression as you would like. So, kind of using that visual picture to understand why taking the medication before meals is essential, it kind of helps, the light bulb turn on, if you will, in understanding how the pharmacodynamics of the medications work.
That is a great explanation. And I bet it's so easy for a patient to visualize, because I was visualizing that as you were saying that. And that's so powerful. And once you realize, oh my God, I need to control those sprinklers or I'm going to have some issues here. I
Yeah.
love that. I hope our listeners appreciate that as well. I'm sure they do. Now, you've done such a great job of laying the groundwork about what can go right with early action.
Mhm.
And we're so encouraged as we move forward in understanding more about Barrett's esophagus. And, we don't like to be the bearer of bad news all the time, but we want to make sure that patients have the information, they're armed with information so they can really have these important discussions with their provider and even get to a provider. So let's talk a little bit about what happens if Barrett's esophagus is ignored or undiagnosed.
100%. I mean, as stated earlier, Barrett's esophagus can progress silently to esophageal adenocarcinoma, which is a cancer that's high risk. And if ignored or underdiagnosed, it has a likelihood and a greater mortality rate that will occur in about 5 years. So it's essential, or I should say, the con of not addressing it or getting earlier treatment is that you kind of miss the window where it's clearly treatable if caught early and deadly if ignored. So we want to increase the awareness of untreated chronic heartburn is not something to just deal with. It's something to address and treat and screen if necessary for Barrett's esophagus.
No, thank you for that. And those are really important points that you've hit. Now, I know our listeners struggle with this. I struggle with this too. Is what advice do you have for patients who are nervous about, number one, even going to their doctor? Because we all downplay, oh, it's not that bad. And when in the moment it's bad, but then a couple of days later, oh, it's fine.
Yeah.
But you said it could silently be working
Mhm.
under and masked by other things. So what is your advice about for patients who are in that situation, who may be trepidatious, who may be nervous, they don't want to face what they feel in their gut could be happening? Like, what do you, or for those supporting loved ones, it's so difficult to get, I know women always complain their husbands never want to go to the doctor. How do you how do you help them? Or maybe they have a adult child who's like, no, I'm fine.
Mhm.
Or a parent. I know my mom was like so stubborn. She was a nurse as well. She
Mhm.
never wanted to go to the doctor ever. So how do you help these people?
Those are all situations that I could totally relate to. I would say there is really no need to suffer in silence. And the first time you or give voice to your symptoms, life will start to change and change for the better. So you really have to be your own advocate when it comes to being in that primary care office, bringing up an issue or a concern. You have to ensure that you communicate what you're experiencing to your family and friends, and remove the embarrassment that comes along with having issues with food, because food is or mealtime is a shared experience regardless of what culture that you're in. And we want to enjoy fellowship around food with family and friends. So really kind of being honest with yourself, understanding that sometimes lifestyle modifications aren't the only things that you need to do in order to treat the symptoms. Medications are okay. They are short term and or can be long term in this case. But once you give voice to what you're experiencing, you're setting yourself up for success, and that is the goal.
I love that. You're such a great, how do you say, advocate or just trusted provider for patients. Like, you have this calmness, and I want to listen to you. Like, if I was in your office, I would want to listen to you and I would do what you said. And I love that. I think that's so important to have that demeanor with patients. So I wanted to call that out. It's beautiful. Are you aware of any resources that patients should look into, or that you want to suggest as they navigate hopefully getting to care, or maybe taking the next step with their providers? Like, any resources, or maybe they've been diagnosed, or maybe they want to learn more? I know I ask a lot of questions all at once, but
that's okay.
You can pick whatever one you want to answer. Sorry.
I mean, there are a plethora of resources. We want to encourage people to find resources that are evidence-based. So tissuecipher.com is helpful, ecan.org is helpful, and nih.gov is helpful to really give some, like I said, evidence-based information. We don't want patients to go to Dr. Google. We want to ensure that we are putting the guardrails around resources that we are confident in that can guide the patients along their journey.
Thank you. Any final thoughts or anything that you want to add? Did we miss anything?
I would just say that reflux is very, very common. If you have not experienced it in your life, consider yourself lucky. If you have experienced it, it is extremely uncomfortable, and it doesn't have to impact your life in that way. It is essential to, give voice to what you're experiencing, create a journal just so you can kind of have good conversation with your primary care provider, and figure out a way to not minimize what you're experiencing, because you might just save your life.
Oh, Tedra, thank you so much for sharing your compassionate insight and practical wisdom with us today. You've shown us that knowing your risk is just the beginning, and patients really must take action, ask questions, and stay engaged in our care. That's truly how we can make a difference. So whether you're newly diagnosed or supporting someone you love, we hope this series has helped you feel more informed and empowered. And you can catch up on all 4 episodes of this series on your favorite podcast platform. And don't forget to share this with anyone who you feel might benefit. Let's keep the conversation going and turn our awareness into action together. And thank you, Castle Biosciences, for sponsoring this special education series. Thank you so much.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.